lesion as a cystic neoplasm, including its aggressive clinical course, tendency for recurrence, and association with certain genetic abnormalities. And it is occurrence in the nevoid basal cell carcinoma. It is also called as Werner-Schwarz syndrome. So let's see the definition of odontogenic keratocyst. According to the World Health Organization, it is a benign, unicystic or multicystic intraosseous tumor of odontogenic origin. Dental lamina and its remnants with a characteristic lining of para-keratinized stratified squamous epithelium and potential for its aggressiveness and infiltrative behavior. Let's see the pathogenesis. The source of epithelium for cyst formation are cell rest of cell, degeneration of stellate reticulum in enamel organ, epithelial rest of molasses. Let's see the clinical feature. Incidence, it is 5 to 15% is very common lesion. Gender, age, it is 2 to 3rd decade by model age distribution. Gender, male is more than females. And site, it is 75% of mandible, molar, ramus region, premolar and canine, in maxilla, posteriors and the canine region. Course of the lesion, it is 50% is symptomatic lesion. Cortical expansion is E and buccal expansion, and 30% is in mandible and 20% is in maxilla. Investigation. Radiographic features, it shows well-defined unilocular or multilocular radiolucency with a smooth or scallop margin. Displacement of the adjacent teeth without desorption. As you see in the picture, a lesion may contain the impacted tooth 25 to 40% expansion of the cortical plate with or without the perforation. Lesion is grown anterior-posterior direction initially. Let's see the variance of OKC depending upon the radiographic features. First one is the replacement type, second extraneous, and third collagen, and fourth is envelopmental. As you see in the picture, they are placed in here. Histopathology. The odontogenic keratocyst is characterized by the unique histological appearance. The cysts are lined by parakeratotic or orthokeratotic stratified squamous epithelium, which is usually 5 to 8 cell thickness layer. Basal layer consists of palisade cuboidal or columnar with a reversal of polarity. The parakeratotic epithelium may often show corrugated surface, as you see here. The cyst lumen consists of desquamated keratin. The presence of intense inflammatory infiltrate into fibrous capsule may cause loss of keratinization, thickening, and development of the retiritis or ulceration of the overlying epithelium. Differential diagnosis for the odontogenic keratocyst are aminoblastoma, dentigenesis, central giant cell granuloma, odontogenic myxoma, and calcifying epithelial odontogenic tumor. Let's see the treatment. It is surgical enucleation, marsupiation, corneal solution act as a devitalizing agent, and resection of the mandible. Thank you.
Odontogenic keratocyst. What is the other name? Keratocystic odontogenic tumor. So it is actually a cyst. When you aspirate the cavity, you will get an aspirate of white, dirty white fluid you will be getting from the cavity. Okay. But it is otherwise called as a tumor. Why is the reason? What is the reason that it is called as tumor? In spite of the particular cavity having a fluid or open cavity which is having a fluid, you call it a cyst. No, but this particular cyst is otherwise called as a tumor. And what is the reason? Can anyone tell me? In spite of it being a cyst, the behavior is going to be like a tumor. It is going to be locally aggressive. Okay, so that is the reason it is otherwise called as KOT, keratocystic odontogenic tumor. Okay, next is, as she said, it is common in the mandible, it is common in the posterior region, it is common between 20 and 40 years of female, like that. Okay, then one other important thing is, it will not cause much of expansion of the mandible. It will try to expand along the or extend along the anteroposterior direction. Okay. For example, if there is a cyst in the premolar region, then it extends to the anterior region till the incisor, then posteriorly it extends till the ramus. Okay. So, if coincidentally, if you would take an X-ray for some other reason, maybe there is a cavity in a 4-5, when you try to take an IOPA, and you could find some radiolucency there, then you go for taking a larger X-ray, you could see a large radiolucency which is extending from the front teeth, from the anterior till the ramus. So till it establishes itself, extends from the anterior to the posterior direction, it does not produce any expansion. General cyst, what you will tell you, you will learn that it will produce a buccal expansion, it will produce a nasal expansion. But for this particular cyst, it will not cause much of expansion. Expansion it may or may not cause expansion. Why? Because mostly it will try to extend between the anteroposterior direction. Once it is done, then it will try to expand buccolingually. Okay, that is another important thing. Next is, as she told, the lining is parakeratinized. The cystod lining is parakeratinized. What is parakeratinized? It has the nuclear, presence of the nuclear will be there. So this parakeratinized epithelium will have a tendency of causing recurrence. So the enucleate பண்ணும்போது complete enucleate பண்ணல அப்படினா remnant அங்கங்க இருக்கும். So what will happen? Frequent recurrence of the condition will be there. For example, if it is any other cyst or a radicular cyst, you open the cavity, you totally enucleate it, then later you may not expect a recurrence because you have completely enucleated it. But in case of a OKC, because it is parakeratinized and you have a lot of smaller cysts, it is called satellite cysts. The smaller cysts, you may not, எவ்வளவுதான் நீங்க curate பண்ணி அதை completely remove பண்ண try பண்ணாலும், you might leave some of the epithelium in the cavity, you might leave some of the smaller cysts surrounding